Hello, hello, and welcome to another Polestar Pilates Hour. Today we got a lot of fun planned to talk about a post-lumbar fusion case. We're a big group today. We're over 1,400 signed up for the webinar, so I'm always curious as to what is it that makes you want to come on to one and not another. So if you ever have feedback, that helps us out, and we certainly want to cater to the masses and be able to bring you some of the best of Polestar, and looking at case studies, who we interview, looking at movement with Shelley Power. So we got a lot of great things going on. Well, today we're going to be talking about a gentleman who is 40 years old. He's a massage therapist, and he's had a lumbar fusion at 4-5. And this particular case is not uncommon. This is something we see quite often, post-lumbar fusion. I'm going to paint sort of an idea in the beginning that I want you to think about as we go through. And I want you focusing on strategy of movement. We'll come back and we'll hit that over and over again. Sometimes when we think of a fusion, we get stuck in structure. We think, oh my gosh, these two segments are fused together, and they are. But I want you to think of strategy, like what's the repeated strategy that keeps insulting Jacob's back? So Jacob is a 40-year-old male massage therapist. He's 5 years post-lumbar fusion at levels L4-5, and he has recently noticed an increase in his low back pain, and that's driven him to look for other solutions, right? He doesn't want to do another surgery. He's already had 2 surgeries. His original back injury was a herniated disc due to a lifting accident 15 years ago. And that was followed by a discectomy, a microdiscectomy that failed and eventually led to a fusion. So here he is again with this same kind of mechanical low back pain, not a lot of radicular or neurological symptoms, but there's something going on, and he is frustrated, to say the least, because now this has been going on for 15 years, since he was 25 years old. Symptoms include guarded movement and standing and walking, inability to sit longer than an hour, and difficulty lifting more than 20 pounds or 8 kilos without delayed pain in his low back. So again, the pain is mechanical, it is centralized, it's irritated with static posture or change from a static posture, particularly prolonged sitting. Now, his job is a massage therapist. So if you think of a massage therapist, typically is either going to be sitting on a stool or possibly standing up over and bent over the client. And he's been doing that for about 15 years as well. So if we want to look at some subjective insights, you know my question that I always ask my patients is, what do you believe you're not able to do right now that you want to be able to do? And so the biggest limitation for him is his work status. And remember, when I ask that question of participation, I'm typically talking about daily activities, things like being able to walk, being able to bathe, to cook, to do the things you would do your daily day, putting shoes and socks on, things that you might take for granted, but with a back pain or back history, socks could be really difficult, bathing, etc. So working is the next one, and working consists of whatever you determine as your work. So his work is massage therapy. And the third category in participation is recreation. So I always think of, how do I weigh it out? If a patient comes to me and they have limitations in activities of daily living, that becomes very serious because they can't do their daily life functions. If they can't work, they can't provide for themselves. Recreation has a little less weight, but it's super important for our wellness, both mentally and physically. So right now, his hiking would be under recreation. Playing with his kids could be daily activities. And gardening is also a recreation thing for him at this time. That is not his job. But the biggest one is he can't work more than 4 hours, and he needs to be able to do that to provide for his family. So when I asked Jacob, what do you believe is preventing you from participating in these activities? He said basically a fear of low back pain with bending or prolonged posture. So here you have somebody that for 15 years, he's had on and off symptoms that started with this initial herniated disc from a lifting accident. The lifting accident was in the gym, right? So he's doing some heavy squats, I'm again thinking of strategy because we're going to see this over and over and over again. But now he also has a component of fear, not just the mechanical pain. So he's afraid to do certain things because of what he has experienced in the past 15 years. We're going to take a look now at the objective assessment from his medical doctor first. This is a slide of his fusion. So you can see very clearly the sacrum down below, and that space in between the sacrum and the next vertebrae up is the L5-S1 space. And I believe this is where he's having his pain right now. The L4, L5 is fused. What you can't see very well, you see little clips in there, is a fusion cage that actually is between 4 and 5, and then the hardware holds it together. So there is no movement. The fusion looks great at L4, L5, and then he has regular movement up above, right? So we would expect him to have movement in the segment of L3, L4, and also to have movement in L5-S1. No other major pathologies of the spine that we could see. The MRI came back negative. Peripheral neurological test, negative. So there's no radicular pain down his leg. There's no weakness down his leg. He did manifest fear of back pain. That's a FOBQ test that we use a lot of times in medicine to be able to see what they believe about their back pain. So right now, he does manifest fear of back pain, which was also mentioned in his subjective information. From the physical therapy measures, looking at him, his posture, he had rounded shoulders, forward head, a mild kyphosis, and posteriorly tilted pelvis. So that's a protective guarding position. And before I even ask questions, you can probably already think of reasons why his job in particular, leaning over his patients, and I certainly know this as a physical therapist as well that does manual therapy. You know, you're working on top of that client on their table, and so your forward head, rounded shoulders, bottoms tucked under, knees are bent sometimes, and it's very hard to keep a very mindful posture in the low back while you're working on patients. So there is something to be said for that. Active range of motion, what I looked at was mainly his thoracic mobility and his hip mobility. My thought on that is if you have low back pain, check the thoracic mobility, check the hip mobility, check the ankle mobility. He did have poor thoracic mobility in all planes. So he was sort of stuck posturally in kyphosis. He didn't have good extension in his thoracic spine or lateral bending, or his rotation was also limited. Strength was normal on all levels. He's a strong guy, very outdoorsy, likes to do athletic things as well. And the neuro reflexes were normal, sensation tests were normal. So what I'm painting for you here is actually a pretty clear picture. And even though he's had this pathology at L4, L5, I don't want you to be afraid of where we're going. The fusion is good and solid. And I'll paint another little picture for us here. If you think of how many vertebrae we have in our spine, I'm just going to pull my little short spine up here. But if you think of how many vertebrae we have so much movement. The average person typically moves from 3 or 4 segments in the spine. And we know that the spine has at least 24 segments, depending if you have fusions or not. I have a 4-level fusion in my neck. Jacob has a 1-level fusion in his low back. So what I'm saying is distribution of movement. If we can get a few more vertebrae moving successfully in this part of the spine above, and we can get his hips restored, we can take that stress from his strategy that he has, that I believe he has, that is putting stress on the L4-5 and now the L5-S1. Before we even start Jacob's assessment, we've just got information that came from us from the medical side. What he's looking for now is he wants to do Pilates, right? He's looking for an alternative intervention. He's heard a lot of things about Pilates. His wife wants him to do Pilates. Based on that subjective information and the medical information that I gave you, what would you hypothesize Jacob needs the most right now? It's an open question. Take your time filling it out. We got plenty of time today. It's just this case study that we're going to work through in detail. All right, let's go ahead and show these, Melissa, and talk through them. So as we take a look at these, let's see what you got there. A professional support system that will give him confidence, increased thoracic mobility, hip mobility, thoracic mobility, core strength, encouragement and support that Pilates can help relieve pain and discomfort. So I'm hearing some things that are working on his belief pattern, and also some things literally working on his strategy, which is great. To break the pain cycle and the resulting guarding with positive movement experiences. I couldn't have said it better. An evaluation by a rheumatologist giving stiffness in prolonged sedentary states. And I don't know that he wants to go back to a doctor, but I always keep my rheumatologist in the back of my mind. And I personally use a rheumatologist as well because I don't like surgery, and I try to manage any of my joint and chronic joint problems with a rheumatologist that is very much holistic in her approach to medicine. I see a lot of thoracic mobility, dealing with the fear with successful movement experiences. So that is great. These are all very good. And some of you are already jumping ahead and giving him exercises, which I think is great as well. It's always great just to start throwing things out there and getting them out there. There's a nice one. It says scaffold Pilates movements, bearing in mind where he thinks he is having pain for him to gain confidence to move on. As you often say, build up success. So little tiny bite-sized successes that pretty soon we have him that he finds a strategy that he can bend forward, he can squat, he can get down on the floor with his kids, he can sit for an hour without pain, that he starts having some strategies that he can use to avoid the stress on that L5-S1 segment. Very good. The next thing I'll ask you, and this has to do, and again, functional tests. So we do a lot of functional tests in Polestar. We call them our Polestar assessment tools, or also our screening tests that we do in the basic training. And these tools we use to be able to say, okay, based on what Jacob wants to do, Jacob wants to be able to garden, he wants to be able to work, he wants to be able to go hiking. And based on what his limitations are, he mentioned that he had thoracic mobility limitations and he had fear. So what functional test would you do? Now, it doesn't have to be a Polestar assessment test, but just think of what would you want to know and see him do to be able to go like, based on the activities you're choosing to participate in, do you have the ability to do those movements in your body? So take a moment, start writing those down. These are things like we often talk about the squat test or half squat test, goalpost, lunge proposal, the spine extension, shoulder mobility, hip extension, foot mobility, any of those kind of things that you think that he might need. And then we'll take a look at it and see sort of how I prioritized it, and we'll work together on that and see what the results were of his testing. And I do have a first question coming up, which I would love to answer. This is from an attendee. Says, how does a person who is fused like Jacob from the above and below vertebra from becoming less stable as is supposedly normal with fusion? So one of the things we're going to talk about today is adjacent joint syndrome. And this is very common, and I want you to think about it. If we have options to move from 24 vertebra, the hips, as well as the knees and ankles in most of our movement challenges, right? Squatting, getting on the floor, up and out of a chair. We have that option. But the average person only uses 3 to 5 of those 24 segments in most of their movement. What are the primary locations that we tend to strategize from? Well, we know in the lumbar spine, it's primarily L4-5 and L5-S1. Now, that creates a problem for Jacob, doesn't it? Because L4-5 is fused, and we're not going to get movement out of there. But if he continues with the strategy of moving in flexion and lifting and bending from L5-S1, pretty soon he's going to have, and this is what the warning sign is right now that he's having, he's going to have pathology in L5-S1. So think of ways that we could distribute that motion somewhere else to be able to minimize what we call adjacent joint syndrome. Let's go ahead and go live on the screen here. So I see a couple of things: squats, T-post, roll up. And roll up, we would have to be a little bit careful. I'd almost want to see more of a roll down or a partial roll up to see what their thoracic mobility looks like. Prone chest lift, half lunge. Good. Z-sit. I see some good ones in there looking at hip mobility, looking at thoracic mobility, looking at the ability to use their hips. And this is one of the things that I was curious about. Remember what I said about his pelvic posture? Does anybody remember? They could plop it into the chat session. What did I say about his pelvic posture and standing? We said he had kyphotic thoracic. We said he had rounded shoulders. Does anybody remember? They could put it inside the chat session. That's right. He had a posterior tilt, right? So the posterior tilt is like tucking under. So if you can imagine, I'm going to go back to my spine here, and you imagine that the motion that he is using is coming from here, right? So these two levels, get my levels right, these two levels are fused. And now when he bends forward, it's almost all happening right here in the L5-S1 space, right? So you can imagine that there's going to be a lot of stress going through there with a posterior tilt. Posterior tilt is going to bring all of this underneath and flatten out that lumbar spine. And because L4-5 doesn't move, all that stress is going to happen right where we don't want it, in the L5-S1. So think of ways already, and I saw some good comments on that last screen, of how to work with some pelvic orientation and how we'd want to see what his pelvic mobility is, right? We'd want to get a little more anterior tilting and more hip mobility in that pelvis to be able to avoid so much stress in the L5-S1. I hope that makes sense, that if he's in a posterior tilt, rounded back, he's going to have all his bending stress and flexion stress is going to go through L5-S1. If we go into a little bit of an anterior tilt, right, now the motion happens. You can even feel it in your chair. The motion happens inside your hips. So if we can get the hips being a little more mobile, a little stronger, then we know we can take the stress off that L5-S1, especially with loaded activities. If he's going to carry a box or he's going to help move a patient or something like that, learning how to be in that little bit of anterior tilt for him is going to be less detrimental than in a posterior tilt. So these were ones that I picked. I looked at goalpost, obviously, to see if the thoracic mobility and the shoulder girdle organization, if it always moved down to L5-S1 in the extension mode. I looked at squat, again, looking at his strategy. When he squatted down, did he go into the posterior tilt? Did he pitch his body forward? Did he put all of the load on L5-S1? The answer to that second one is yes. So his strategy was posterior tilting, doing more flexion from the lumbar, very little flexion in the knees and ankles and the hips. So you can imagine that's probably why he hurt himself 15 years ago to begin with, that he damaged that disc in a heavy lift with a squat activity. He never was re-educated on how to squat correctly. So even though he had the fusion years later, now he's still continuing with that same strategy. He hasn't figured out the hip mobility strategy or the thoracic mobility strategy to take the load off. And this is where we become incredibly successful, often without even knowing it. We have a comment from Farah. Farah says, should patients with fusion avoid any back extension poses in Pilates, such as swan? And it's a great question, but I'm going to put the question back to you a little bit, Farah. I think obviously in an early stage of a fusion, so let's say the first 6 months, we really don't want to move at all in around the fusion site because the bone is healing around the fusion, the cage, or the bone graft. And that being said, I even will take them out sometimes as far as a year of not doing anything through that area that was fused. But I want you to think of, could I introduce in the Pilates environment some thoracic extension without going into the lumbar? And where might I do that? So use the chat to put down a couple exercises that come to your mind that you could use that would totally protect the lumbar spine and still give the thoracic the ability to go into flexion and extension without loading that lumbar area. What do you think? So I see swan prep, prone press up, pre-swan. Now, somebody said what I was looking for there. That was Jean, said over the ladder barrel. I see a couple of you doing that, Michelle as well. So the ladder barrel is a fantastic way where they just lay on the barrel. Their lumbar spine is safe. You could do the same thing, putting a pillow underneath their pelvis, You can use the chair off of the trapeze table and put a pillow underneath their pelvis and just block that lumbar spine so that it doesn't go into extension and that you're really working on that thoracic area. So, Bear, I hope that makes a little bit of sense that, again, extension doesn't mean that you're extending from every single vertebra. As a matter of fact, what we want to teach Jacob is how to move from other vertebra in his strategy other than the L4-5 and L5-S1. We want to distribute that movement. So L5-S1 is at the bottom. So where we go to from there is going to be in the hip mobility. So we need to make sure that we have hip extension and hip flexion that can allow him to keep that load off of those posterior fibers where he's having pain on that L5-S1. Yeah. The other ones we looked at were breathing circumference. I wanted to know if his rib cage actually expanded and narrowed. That was really important to me because that would tell me how his abdominal muscles and his back muscles work together in being able to expand the breath, or if he was an accessory breather. I also wanted to know if he was a Valsalva kind of guy, right? So if he goes to lift something, does he go, huh? And he sort of grunts and he increases that internal pressure? And the problem with that is that it's not going to be sustainable. If he gets tired, or if he has to carry a package or a box across a street or something like that, he's going to feel the wear and tear in his body because his stability comes from a Valsalva, not from the other. So you can think of a great exercise in the Pilates area that teaches us to be able to sustain control over a long period of time with constant breathing. Can you put that for me into the chat session? What do you think that is? Julia, way to go. You get the ding, ding, ding award, right? It's the 100. So the 100 has an incredible application. Now, we can modify the position of the pelvis as we need to, and we can modify the length of the legs and the levers, but it is that breathing through load of the 100 that is so valuable. I had somebody telling me, that they didn't like doing the 100, so they took it out of their mat work. And I was like, no, that's one of the best exercises. Now, do you have to come up in the full roll up and have your legs out 2 inches off the ground? No. But the concept of the exercise is sustained load, the weight of the gravity on the legs, while you are breathing. So it really teaches our trunk and our core to work in with a proper amount of intra-abdominal pressure. And that's really what we talk about control. It is this intra-abdominal pressure that's so powerful. All right. And then swan, we mentioned already. A lot of you put swan in there. I did want to look at pre-swan. I didn't take him into a full swan, but I do want to know if he has any thoracic extension. And remember, he was kyphotic in his posture, and he is rigid there. So that's a concern of ours. We're going to have to maybe do some manual therapy there as well. Let's move forward. What do you believe could help regain Jacob's ability to sit, stand, and squat again? What are going to be the key things, especially as they pertain to us as Pilates teachers? What do you think that's going to look like, right? And so we're saying, what do we have to offer Jacob as Pilates teachers that could help him with his sitting, standing, and squatting? It's a great question, right? And you have the answer. So I want you to dig deep and try to think of what is that answer? What is it that we have to offer him that almost immediately could improve his ability to sit, stand, and squat and improve that tolerance? While you're doing that, I'm looking at some of the other suggestions that came through besides hundreds. There's some good ones in here. Supine arms and reformer also helps control that same idea. Leg press, scooter and the reformer, some good things there, yeah. So, all right, I see some new things coming in. Leg press, scooter, bridge, good. Let's see what else comes across there. Core, footwork on reformer. Why do you think footwork is so important in this one? Maybe standing leg pump on the chair. I saw that. Assisted squats, very good. Hip mobility. Because really what we want to do is we want to change his strategy, right? We want to change his strategy to be in more of a hip and ankle strategy and thoracic strategy rather than a lumbar flexion strategy that he has, which he's probably always had. This is a really important, that's why I thought of this case, and I thought this case really teaches us about strategy. We're not dealing with the treatment of his aftermath of his surgery. We're dealing with something that probably was before he even herniated his disc. So if you could think of how would we train our teenagers and our young adults how to lift weights and how to squat correctly, if we're teaching them how to disassociate at the hips, how to maintain proper axial alignment. And that's what all these exercises are doing for us, right? That's what we're looking for. Is think of the bigger picture that we want to achieve with Jacob. We want to make sure that when he's sitting, he's not rounded back. So how do we teach him to do that? Maybe we teach him to sit on a oov or the new balance sit to be able to create or a ball, just to create enough instability that he has to be able to maintain that dynamic alignment that's going to keep him out of hanging on those ligaments. How about standing? What's his posture in standing? The posture I saw was rounded shoulders, kyphotic spine, forward head, and posterior tilt. So in Pilates, we're going to start working on that posture, that dynamic posture. How does he stand up against a wall? How far away is his head from the wall? Does he have mobility in his shoulders? He has to use his arms and hands for a long time. If he loses that mobility there, he's very likely to have brachial plexus problems, carpal tunnel problems, neck problems, radiculopathies in the neck as a massage therapist that doesn't do activities to restore and maintain thoracic mobility. Got some great things coming up here, everybody. So very good work. So here's a little bit of insight. So we've sort of figured this out already, and Jacob's restriction in his thoracic and decreased hip mobility appear to be associated with the excessive stress on L5-S1, right? The potential risk of adjacent segment syndrome is very high for him. High not because of the surgery, not because of the risk factors of a fusion, but because of Jacob's inherent strategy of how he moves. Strategy never changed after fusion, and more than likely it existed prior and was responsible for the original injury about 25 years ago or 15 years ago. The body continues to try to move from the lumbar spine as its primary strategy. This is the big movement strategy we want to take home now as we move into our interventions that he's going to be doing. Ali Green put a question in the question box. Says, curious about footwork on reformer if still healing. Is the compressive force okay? Does it really just depend on the person proprioception and being careful with the amount of force from the springs? It's a great question, Ali, but he's already 5 years post-surgery. So the 5 years is, 6 months is more than enough time for that to heal. Compression usually doesn't make a big problem for us because remember, standing up has more compression than doing a 2-3 spring footwork on a reformer. And the base of support is so big that it's safe. So you could be pretty comfortable, Ali, thinking that you could use the reformer even early in the rehabilitation. As soon as usually the doctors don't want them doing any activities for 2 to 3 months, sometimes even 6 months, mainly because they just don't want an accident. So they'll sometimes keep these individuals in a brace or they'll restrict them to a walking activity. But you can be assured that if they're walking a lot, that they're probably more than capable of handling that load that a reformer would provide to them in their low back. What might be something that you would want to look at pertaining to their alignment while they're doing it? Or let's talk Jacob. What would we want to pay attention to for Jacob in his posture on the reformer? What would be some of the important details that we'd want to pay attention to? Yeah, Ali, that's it. His pelvis, right? So we'd want to start gradually, and you can't do it too fast, but gradually bring his pelvis back into a little bit more of a neutral or anterior tilt from that posterior tilt. And we'd want to bring his thoracic a little bit more into extension so that his body is stacking up nicely on top of the pelvis. And now he has proper load distribution. He's not hanging on those ligaments in his low back or the back of his neck or the back of the thoracic spine. How can we help Jacob regain his thoracic and hip mobility and re-educate his movement strategy? And I'm more interested in the movement strategy. I sort of gave that away in the question, but really I want to focus on his movement strategy. How do we get him away from that posterior tilt in his squat, in his sitting, in his lifting, in his daily activity? While you're answering that, we got 2 questions up. One is from Heather Peavy. She says, do you think this fusion could cause a full dislocation of the hip due to the limited movement and tight hips? And I would say no, I wouldn't be worried about that. What I'd be worried about is that he does so much guarding and tucking that he actually loses some of that nice deep socket movement in the hip. So a lot of times, if you think of certain athletes or performers that are often in posterior tilt, like a ballet dancer, a lot of times their femur is pushed anteriorly inside the socket. It's not dislocated, but it's a little bit anterior on that labrum, puts a lot of pressure on that anterior medial labrum and can cause some pathologies there with certain movements. So that is important to think of, but I wouldn't be worried about a dislocation. It's very hard to dislocate a hip. What I'd be interested in is thinking of exercises like quadruped or something where they can start doing some hinges and allowing that femoral head to go deep into the socket and back towards the rotators of the hip and pelvis, back towards the glutes, and really deepening that mobility around the head of the femur so that his pelvis now has more mobility. Another question is from somebody in the group today. Says, can a person who is fused do footwork with heavy springs to positively affect bone density without worrying about compressing the spine too much? And the question that I would ask right back to you is, think about how much gravity is on their body weight, right? So they're going to have less stress, even up to like 3, maybe even 4 springs, than what it would be on their body doing a full squat. So I think you're pretty safe in making that assumption. I don't often think of bone density challenge coming from the Pilates equipment. I think we have to get them outside and have them going up and down stairs, have them doing some, hiking and activities that are consisting of gravity and a vertical orientation to be able to create that stimulus that's strong enough to tell the bones to work. Remember last week, if you missed it last week, we talked about bone health. We talked about how bones regenerate on a continual basis and what kind of load has to be on those bones to create that negative impulse that brings that calcium deposit to it. So great questions. One more question before we open up this screen. Do you use the OOV to positively affect his alignment? And if you know me, you know I love to use the OOV. I'm pretty skeptical of most props that come out. And about 10 years ago, met Daniel Vladeta in Australia. And I just fell in love with this idea of incredible instability. It matches the body's orientation, and it provides such incredible stimulus spontaneously that the body goes through its own kind of reorganization neuromuscularly at a subconscious level. And I love subconscious orientation. So for me, yes, this is certainly a big piece that I would use with Jacob. And the other nice thing is that because he has to maintain that balance of the pelvis on the OOV, and we're asking him to disassociate his hips and his shoulders and to move those legs around, that's going to be a fantastic way to try to modify his strategy. So great question. And the person in said, love the OOV, and he's Polestar educated. So thank you very much for that comment. Let's go ahead and show the screen. So here we're going to see a lot of disassociation exercises, which I'm very happy to see. We're looking at, and again, all disassociation means is that you maintain some degree of control of part of the body and the other body moves on it. It's a way of introducing strategy. We don't really move like that in life. We're very much integrated animals. Pelvic clock in all positions. I love that. I think that, again, think of pelvic clock even up on top of the OOV or on the balance sit or on a ball. You could do it on the ball. You could do it in your chair right now, just sitting down and rocking the pelvis and moving in all directions. I'd rather have load in all directions than static load for a long period of time on those tissues. Knee stretches, footwork on the trapeze bar. Great ideas. Hinges and quadruped, some of my favorite. By the way, I'm teaching a master class tomorrow virtually for Australia. That's going to be at, I believe, 5 o'clock Eastern Standard Time. You can check out Polestar Pilates Australia. I know there's still room, especially since it's a virtual reformer class that I'm going to be teaching. It's going to be about flow. So that little commercial there. Love it. Train him in neutral as much as possible. So just giving him that awareness, trying to avoid that tension that he would, naturally feel in a posterior tilt or a forward flexion. There's a question in the chat that I just happened to pick up from Michelle Gorga. Great question. Could I use slightly deflated ball under the hips with scissors? And that gives the same idea. I'm sure this is sort of maybe where Daniel got some ideas as well, was using deflated gym balls or some of the different things that we use for proprioception and to put the pelvis on it. So that's a great place to start if you don't have an OOV. Fantastic. All right. So what principles of movement would you prioritize for Jacob? Let me reiterate the principles for you because they have evolved a little bit, but we're looking at things like alignment. We're looking at breath. We're looking at mobility. We're looking at control and load management and movement integration. So we've sort of said we really want to shift his strategy. What do you see as being the principles that would help us the most to shift Jacob's strategy? And I see here another one from Joanne Pegler said, need practical movement strategies for getting into and out of bed, best to practice before surgery. So remember, he's not acute anymore, but these are really powerful things to do even in prehab, right? So if we know somebody's going to be having surgery, it's great for us to be able to teach them some good movement strategies that minimize the load of where that is going to be. So if they have a total hip replacement, how do we modify that? If they have a hip, back surgery, neck surgery, shoulder surgery, how do we organize them ahead of time so that they can recover very quickly? All right. So what principles of movement would you prioritize for Jacob? Mobility is the one that is leading the way. They all are great. So do not feel like one is better than the other. But I do think when we design programs, it's worth us asking this and hypothesizing for Jacob, where do we want to get him moving, right? We want to get hips moving. We want to get thoracic moving, right? Then we want to make sure he has control, right? Yeah, that would be like the disassociation exercises you guys listed. I talked about breath being able to create that intra-abdominal pressure. Alignment of the axial skeleton is his head and his rib cage and over the pelvis, right? And then the movement integration. Can he squat? Can he get out of bed? Can he do all those things? They all become incredibly important. But to start, I would agree with the masses here that mobility might be the first thing that I address, is making sure that there is mobility in those hips. There is mobility in that thoracic. So then we can start working on the alignment and the control of that movement. Remember, you cannot focus on control if there is no mobility, right? If you're rigid, there's no sense to work on control. So we get mobility first, and then we can move into them. Great responses. All right, so let's go ahead and look at the summary here. Focus on functional activities for Jacob, sitting without pain, overhead activity without pain, walking and standing without pain, gardening without pain. These are all the things I sort of think of, like, how can I, help him in his functional activities? The structural limitations, this is where the mobility comes in, thoracic restrictions, maybe myofascial restrictions around his hips. You might need to send him out, or you might just be patient with your exercises to restore that, with the emphasis being on things like pre-swan and using the barrel. Those are going to have much longer lasting outcomes than a simple manipulation. And then strategic limitations, things like squat strategy, thoracic extension strategy. Likewise, I didn't talk a lot about thoracic extension strategy, but when you think of, he wanted to play tennis, let's say, and he had that kyphosis and limited shoulder mobility, where do you think his reach or his extension is going to take place? It's going to hit him right smack dab in the middle of the low back. So again, looking at how do we work on these strategies. I have a question from a dear friend of mine from England, Whitney Vavel. It says, what recommendations do you have for failed lumbar fusions and pseudoarthrosis? When you look at the more complicated outcomes. So again, if we can, let's say that Jacob went another 5 years with the same strategy, he might fall directly into what Whitney's talking about, of failed lumbar fusions and also a pseudoarthrosis, where, it's just there's almost like a fusion of the bones around, and the arthritis gets so bad with the surrounding joints. And That's what happens quite often with failed low back surgeries, right? And I think the reason why we have so many failed low back surgeries is because we really don't pay enough attention to the strategy that they had that was a problem to begin with, right? So when we watch people move, whether the strategy came later as a compensation pattern or whether it happened before as a behavioral pattern, we must address those. Even though we think the surgery solved the problem, it got rid of the herniated disc. It stabilized that segment so there was no longer pain coming out of that segment. However, if the strategy is still there and that joint is fused, now what you're going to end up with is segments above and below or other parts of the body that are going to compensate for that limited strategy. Years ago, and I've told this, we cited this research back in 1996 in Southern California. We did a study looking at segmental mobility in healthy individuals who had never had back pain, who had never done Pilates. It's pretty hard to find these days. And we took these 25 or 30 students, and we had them all measure forward bending, and we looked at their strategies. And what was so interesting was that in the strategy of forward bending, almost all of them had the strategy of moving from L4-5, L5-S1 in their low back, and almost had no movement in the upper lumbar or the thoracic spine. We then split them randomly into two different groups and had the control group just lay around on a table for 45 minutes, came back and did it again. And we also had the other group go and do their first time Pilates reformer class. That class had things like footwork, feet in straps, bridging, roll downs, quadruped. I think that was about it. That's about as far as we got in those 45 minutes. And then we measured both groups again. Both groups came in, but they had very different outcomes, even in those 45 minutes from their pretest. Pretest looked alike. The post-test of the Pilates did not. What we found in the post-test of the Pilates was that they had a greater total range of motion, which would make sense. We did feet and straps, warmed the body up, spine articulation. We saw increased mobility in the upper lumbar and the thoracic spine. Again, roll down, bridging. We'd expect to see that. But the most important finding was that L4-5 and L5-S1 decreased by as much as 50% in their movement. So these individuals in one session of Pilates reformer classes had a complete shift in their strategy that gave them more total range of motion in bending forward, but reduced the mobility, the load in the L4-5, L5-S1 by 50%. And we believe that a lot of what we see that is so successful in our work as Pilates teacher really is built around these strategy changes of increasing access to greater mobility with less extreme mobility. So what I mean by that is if I had a strategy and moved from 3 segments and now I have 9 or 10 segments I can move from, I have 3 times the amount of mobility. And if I only need half, that means I'm only using 60% of the range of motion I need from any one segment. That's fantastic to think of. Distributing the range of motion or distributing movement distributes force. And that's really one of our key principles in Polestar. Have a question that says, what if the client has osteoporosis regarding bending or roll down? So how do you get mobility, right? So in osteoporosis, you've already sort of gone too far in your bone demineralization process. And so we do have very strict guidelines in healthcare and in fitness that we do not do forward compressed flexion in the spine if they are diagnosed with osteoporosis. The main reason being, if the area, the trabecular bone resides in the body of the vertebra, and the particular sort of strength of the bones up in the upper lumbar and lower thoracic are actually thinner than the more heavier weight-bearing bones down the lumbar spine to begin with, right? So if I have weakness in the trabecular bone here in the body and I start doing a lot of flexion, what often happens for them then is they have a compression fracture of the vertebral body. That's why we restrict forward bending with compression for people with osteoporosis. Now, the back of the spine is cortical bone. And this cortical bone is very strong. And the cortical bone does not have the same restrictions that we see in the trabecular bone. So what that means is that we can go into extension without a precaution with osteoporosis. The catch sometimes is that people that have osteoporosis also might have a stenosis. A stenosis that's a narrowing, has an extension precaution, and an osteoporosis has a flexion precaution. So the way we get around that is we start working with them in body awareness, good hip mobility, working on vertical axial load. We try to keep them out of too much flexion, especially in that mid-thoracic to upper lumbar. We try to restore thoracic extension so they can still stand upright without causing stenotic pain. And that gets to be more complex, requires a little more thought, a little more focus on that, and making that, accessible to them in their daily activities. What it also typically means is they modify their activities. So they're not going to be doing a set of hundreds rolling up on the ground, but we might be able to do it with them standing up or do it in a different position that they can be breathing and using their legs as a load. There was a question that came up by Tracy. It said, does fusion hardware ever limit any range of motion in adjacent vertebra or facets? Typically, no. Typically, what you'll see is the range of the hardware on the facets really is only the length of those vertebral bodies. And they're getting very creative now with artificial disc and with wedging and other things that they're able to do that do not limit some of those range of motions that the fusion does limit. So you're going to see more and more things like artificial disc, and maybe we'll do an artificial disc case study in the near future. If that's interesting to you. We're seeing more and more of them coming out. The other question came in from Karen. It says, do you adhere to absolute no flexion with people diagnosed with osteopenia? Osteopenia, no. Osteopenia is just a stage going towards osteoporosis. And what I would do is try to teach them they need a little bit of flexion, my personal opinion, but they don't need it with extreme compression. So doing things like roll up and roll over, those I would say would be contraindicated. But being able to know how to do things like maybe doing a spring-assisted roll down and really working on their axial length, being able to work on other activities with a chair that could give them assistance through those ranges of motion without compromising or causing too much compression. It's a catch-22, isn't it? If we don't load the vertebra, we don't signal the vertebra to build bone. But if the bone is too damaged, then the load could cause fracture. And it's a fine line, and that's why all the osteopenia and like good bone health, we want to load those vertebrae and get them nice and strong so that as we age, we don't suffer from osteoporosis that then would say, no, you can't do that flexion anymore. It's too high of a risk of fracture. That makes sense to you. Great question. Got another question here. What do you mean by forward flexion with compression? Isn't there always some compression with forward flexion? Not necessarily. If you can create axial length while you're doing forward bending, and you have a lot of segments to move, then your strategy could be minimal compression on a vertebra with flexion, right? You have disc, you have ability to move, and if you think first of going up and then coming over, you are not putting tremendous load onto that vertebral body, especially if you have 7 or 8 segments that are part of that. So, for example, a bridge laying in supine is not going to create, even though it's flexion of the spine, it is not going to create a tremendous amount of torque on those anterior vertebral bodies. So that would be a place I would start with something that has less risk and seeing how they feel. Now, that doesn't mean go out and try to do compression load on people with osteoporosis. What I'm saying is, if you are osteopenic, like the question was, make sure you understand the difference between osteopenia and osteoporosis. Osteopenia just means that they're starting to have some bone demineralization. Osteoporosis means that they're at high risk of fracture. Very different. Do not confuse those two. So the question is, how can we facilitate things like some mobility in flexion without having too much load? Distraction can also help facilitate that. Let's see, a couple other questions here. We're just about the end of our time. A great one, Julie Jansa said, I had an ALIF. That is where they go in from the side and they actually do a lift. and a wedge in between the vertebra, and that is particularly done for stenosis. Julie can let us know whether or not, without violating HIPAA, if that was the case. But that lift actually makes it so that it creates space around the foramina that the nerve root comes through. So if we took a look at the spine here, we could imagine that the space around that spine, if we can just increase the space between the vertebra, we can take the load off of the nerve roots. And that's really what we're looking to be able to do. All right. Another question from Ali says, could you talk about rotation for osteoporosis and lumbar fusion? So again, let's not compare osteoporosis with fusion. So typically, if you have osteoporosis, you're not a good candidate for fusion. They'll often do something called an osteoplastic. I forgot the name of it. But they basically take a sort of like a cement and they balloon it into the vertebral body to try to increase some strength where the vertebrae have collapsed. What we're talking about now is a fused spine, typically of somebody relatively healthy in their spine, and looking at how that moves. Now, if they're fused, to answer Ali's question, there is no rotation in that segment. There is no side bending in that segment. There is no flexion extension in that segment. So what ends up happening then is the segments around it are going to be responsible for that rotation and side bending because you do not have that available to you. And the more segments that we do not have movement in means that there is going to be a segment or a few segments that move too much if we continue to do a lot of the rotation work or the side bending. So that's why, for us, I want to focus on this idea of distribution of movement equals distribution of force. How do we shift the strategy to make it so that no segment is having abnormal stress that is causing trauma, but all segments are having enough stress to maintain health of the bone tissue and the connective tissue? Denise Mafia says, can we do a case study on cervical fusion? Would love to do that, so I'll bring that up. Thank you for the suggestion. And then Yara says, what precautions do you recommend in spinal fusion with surgical cement? So again, typically the procedure that's going to happen in a fusion is to make it so that it doesn't move. That's what a fusion is. So a fusion will remove the mobility and restore the height of that segment so that there's no pressure on the nerve root. There's a lot of different styles of it. There's cages. I have a 4-level fusion in my neck, and they used plates, and they used cadaver bone, and they used a special chemical to make the cadaver bone grow into my bone. So now when you look at x-ray, it just looks like solid bone for 4 levels with a plate on the front of it. So every surgeon has some different techniques. Every country has different things that they're doing. I think the one that's the most exciting today is looking at the artificial disc. So instead of fusing somebody, they're actually putting an apparatus that does restore mobility to that segment. They're still working through it. There's still some that have had failed surgeries, but there's more and more successful ones. The cervical spine especially has shown to be successful with the artificial disc. Let's see. There was another comment here from Tahira. It said, I'd really enjoy a case study on recovery lumbar and or cervical artificial disc. So I'll put that in the hopper for you. That's all right. Do you suggest fused at L4 or 5? Do not play golf. Again, I don't create the restrictions, right? What I do is help people to work within their restrictions. So if they have an L4, L5 fusion, they need to be able to do rotation, but rotation primarily comes from the thoracic spine and the hips. So if they have good technique and good mobility, somebody with a lumbar fusion could theoretically play a light game of golf. They could use carbon fiber shafts. They could do a half swing game so they're never putting too much stress to the lumbar. And I'd have to ask their surgeon. Most surgeons are going to say, oh, don't play golf. Please don't put rotational stress through my surgery. But, that people are going to do what they're going to do. So if we can help them by giving them more mobility and more access to the spine, that could help them out. Listen, it's been you guys have been awesome today, and you have asked so many great questions, and this is where we want to go. This is the kind of thinking we want to stimulate. We'll bring a lot more fun things to you. I think we're going to take a break during Thanksgiving. So I first want to wish you here in the United States, we have our Thanksgiving holiday next week. It's my favorite holiday because I get to eat food, hang out with family, and I don't have to buy anybody gifts. But the most important thing for me is just being grateful. I'm grateful for God. I'm grateful for my family. I'm grateful for my career and for the friends and the roles that I've been able to play in my life. And I'm grateful for you. So I just wanted to do a big shout out and tell you how thankful I am to all of you for being supportive of this webinar. I do want to let you know that we have a couple courses coming up, one in particular that I'll be teaching in the winter, and that's critical reasoning again. So that's going to be on the farm. And if you have any desires at all to come visit the farm here in North Carolina, you let us know and come reserve your spot. And we'd love to have you here for the critical reasoning course. Other than that, there is another knee and hip course with Beth Kaplanik, who will be, that'll be happening later on this year. And that will be broadcast as well. So that'll be streamed. And just wishing you a great holiday. And if you don't celebrate the holiday, just be grateful during that week. You can think of us as celebrating that. And lastly, and most importantly, remember to be kind. And I'll see you in 2 weeks.